Hello everyone and welcome to today's webinar. I would like to remind you that this conference is being recorded. At this time, all participants are in a listen-only mode. For those connected by telephone requiring operator assistance during the call, please press *0. Web participants requiring support should use the chat feature on your screen. I would like to now turn the meeting over to your moderator today, Brady Como, Program Intern at the Canadian Foundation for Healthcare Improvement.
Hello and welcome to today's webinar, Opioids in Our Children. Resources, best practices, and opportunities to support effective and safe prescribing and use of opioids for acute pain in children and youth. As mentioned, my name is Brady Como, and I will be your host today. And I am joined by Dr. Katie Burney, who will introduce themselves in a bit. We are pleased to provide simultaneous interpretation for all CFHI webinars. This may result in a few quick pauses in the dialogue today. We invite you to participate in our chat box in either official language. I also encourage all participants to ask any questions or share thoughts you have throughout the webinar in the chat box as well. And if time permits, our hosts and our speakers will address them during discussion periods, and if not, we will follow up post-webinar. You also may have noticed we have changed our title from Safe and Effective Prescribing to Effective and Safe Prescribing. This was flagged by our patient partners because for them, the assumption is that anything prescribed by a clinician will be safe at a minimum. This is the baseline. The next step is to talk about how do we share resources and best practices that are effective. Safety is always in mind for any medication. How do we then move to effective use? This comes from the lived experience that the biggest barrier has not been from access, but from lack of access. So as I said, welcome to today's webinar, and I would invite participants to please use the chat feature to introduce yourself and where you're joining from today. I would also like to start by acknowledging that we are meeting on land that has been inhabited by Indigenous peoples since the beginning. In particular, we acknowledge that we are broadcasting this webinar from Ottawa, which is the traditional and unceded territory of the Algonquin Nation. We recognize and deeply appreciate the historic connection to this place and the opportunity to gather here today. I encourage all participants to share in the chat box the territory and land you are joining from today. And I will now turn to my co-host, Dr. Katie Burney, to tell us where they're joining from.
Hello all, thanks Brady. Very excited to be here today and co-hosting on behalf of SCIP, or Solutions for Kids in Pain. I would like to take this opportunity, I'm calling in from Southern Alberta, and I'd like to take this chance to acknowledge the traditional territories of the people of the Treaty 7 region in Southern Alberta, which includes the Blackfoot Confederacy, comprising the Siksika, Piikani, and Kainai First Nations, as well as the Tsuut'ina First Nation and the Stoney Nakoda, including the Chiniki, Bearspaw, and Wesley First Nations. And the City of Calgary is also home to Métis Nation of Alberta Region 3.
Thank you, Katie. So as I mentioned, I will be your co-host. My name is Brady Como, and I'm a program intern at the Canadian Foundation for Healthcare Improvement. And I will let Katie introduce themselves.
Thanks. So I'm Assistant Scientific Director for SCIP. I'm also a psychologist and an assistant professor in the Department of Anesthesiology at the University of Calgary, and here on behalf of SCIP and our great partnership with CFHI.
Thank you, Katie. As I introduce our guest speakers, I'd ask that you please take a moment to introduce yourselves in the chat box as well. So as I say the names, I invite the speakers today to introduce themselves. So we'll start with Stephanie Paravan. Stephanie, we might have a connection issue, but I'll move on to Isabel Jordan.
Well, hi there, I'm Isabel. Can you folks hear me?
Yes.
Yes? Okay,
Yep.
good. I'm Isabel Jordan, and I'm calling in from Canada's West Coast, which is the traditional territory of the Squamish First Nation. I'm a parent of 2 kids. I'm a patient partner. Both my kids experience chronic pain, and we have an experience with our oldest, who is almost 19 now, in using opioids. So I'm here to present on my perspective.
Thank you, Isabel. And I think, Stephanie, is the line open for you now?
Can you hear me?
Yes, I can.
Okay, great. Hello, everyone. My name is Stephanie Paravan. I am a caregiver of my 13-year-old son, who is medically complex. I also have another son who is 15. I am a patient partner with various different organizations across Canada, but based here in Ottawa.
Thank you, Stephanie. And Samina.
Yes, hello everyone. I'm Samina Ali. I'm a pediatric emergency physician at the Stollery Children's Hospital in Edmonton, Alberta, which is situated on Treaty 6 land and territory. And I'm also a professor of pediatrics and emergency medicine at the University of Alberta, where I do research into children's acute pain. And I have 3 children of my own, one of whom is pictured right here on your screen right now.
Thank you. The objectives for today's webinar are to improve the effective and safe use of opioids in children and youth by providing a brief overview of SCIP, CFHI, and our work together, share the importance of creating and sharing helpful resources and best practices, and discuss how we can collaborate and coordinate to create and share resources and spread best practices. And to get us started, we will now provide a brief overview of CFHI, SCIP, and our work together to improve effective and safe prescribing and use of opioids in children and youth. The Canadian Foundation for Healthcare Improvement, or CFHI, is a not-for-profit organization with a mission to collaborate with partners to identify and spread proven innovations to improve healthcare closer to home and community in areas of shared provincial, territorial, and federal priorities. The impact of our work is lasting improvement in patient, family, and caregiver experience and health, work life of providers, and value for money. We believe in the collective power for change, so partnering with others where we can add value is central to our work and vision. I'd now like to hand it over to Dr. Katie Burney, who will get us started with SCIP's strategy and provide a recap of the reason we are all here today.
Hi, everyone. So for those of you who aren't familiar, SCIP is a knowledge mobilization network funded by the Networks of Centers of Excellence, or NCE. SCIP's based at Dalhousie University and co-led by Children's Healthcare Canada. And SCIP really seeks to bridge the gap between current treatment practices and available evidence-based solutions for children's pain in Canadian institutions. And really where we start from the problem is we know that Canada is a world leader in children's pain research, but we know from a number of quality improvement and other research initiatives that research really isn't making it into practice. So there's still a large number of children, about 2/3 of children who are in Canadian hospitals, who experience painful procedures without any pain management. Most caregivers say they don't know how to manage or don't feel confident managing their child's pain. We know that healthcare professionals get little or relatively little pain education as part of their training. And there are only a few children's health institutions in Canada thus far that have made a certified commitment to pain management in children. So our vision is really to have healthier Canadians through better pain management for all children in Canada across any type of healthcare setting in which they may be receiving care. And we're doing this in a number of different ways. Certainly, we're focusing on doing this in partnership through coordination and collaboration through great partners such as our partnership with CFHI. We're working with knowledge producers, so researchers, scientists, clinicians, families who are creating knowledge, as well as those who are using knowledge. So that includes 48 member healthcare institutions serving children that are part of Children's Healthcare Canada. And we have 4 regional hubs across Canada within SCIP itself that are really working to embody that leadership and that change to mobilize knowledge to improve children's healthcare. We have more than 100 partners in Canada and around, and then of course we use a patients-included approach and partner with people with lived experience in all that we're doing. So we're really here today to focus on acute pain in children and opioids. So acute pain in children is incredibly common and it's often poorly managed. Appropriate pain treatment reduces harm and risk of acute pain to keep it from transitioning to recurrent or chronic pain over time. This comes about in context of acute pain such as fractures, as well as acute pain following experiences such as surgeries. And we know that there's often an over-reliance on one form of treatment, usually pharmacological medication options, but really effective pain management requires a multimodal approach that takes into account psychological, physical, sometimes procedural in the context of acute pain factors in addition to medications. And really interestingly for our conversation today is in the context of opioids, youth are often first introduced to opioids via a prescription for acute pain. So this is a really critical time for us within the healthcare system and for youth who are receiving an opioid prescription for acute pain to really make sure we're doing this in an effective and safe way. And our goal is really to work together to spread the tools that exist to support this goal, and also to identify if there are additional partners or additional resources or tools that can support effective and safe use and prescribing of opioids for acute pain in children and youth. Our goal, we had a meeting in February for those who, some attended, I know some didn't, and our goal were really to discuss the priorities and activities of children and youth and caregivers and healthcare providers for opioids and acute pain across Canada, to find synergies to collaborate and coordinate, to share existing resources and to create new ones, and to really spread best practices. Before this meeting, we had a stakeholder scan. We did a published literature scan and looked at published peer-reviewed articles that were relevant to this area. And we had 29 different stakeholders from across Canada that attended that initial meeting in February. And it represented a number of the organizations you see here. So Pan-Canadian health organizations, healthcare providers, regulatory and policy officers, knowledge brokers, patient and family partners, and senior administrators. And we look forward to continuing that dialogue today with some of you who were there, as well as with others, as we recognize the opioids for acute pain in children is a pressing issue for many of us across Canada. So with that, it's my pleasure to turn it over to 2 incredible experts to share their experience, Isabel Jordan and Stephanie Paravan, who can provide some of that expert lived experience on the importance of the topic.
So thanks very much for welcoming us here. Because of our experiences, Stephanie and I were asked not only to share our narratives, but also to assess the usefulness of some patient-facing resources. So I think I should be able to move slides. Oh, there we go. I'd like to preface my comments on these resources with a caveat that I wasn't given them or anything like them when our son was prescribed opiates for his acute pain. So in being asked to assess the usefulness of them, it's really quite a bit after the fact, and maybe something at the time would have been better than nothing. So I can tell you in looking at them after the fact that for the most part, all the resources we were looking at address very similar issues in slightly different ways. They explain some risks. They explain things like, in kind of a very high-level view, how to store opioids. They talk about safety, but none of them talk about benefit. Some of them say to contact your medical team, but they don't say who that might be, or who the best person, or who the best kind of clinician to contact about different kinds of issues. In the end, for me and for Stephanie, as she and I spoke about this, what they don't address were some of the big issues that our families had when our children were prescribed opioids for pain. And I'll go on and talk about my narrative, and then Steph will talk about hers. So just over a year ago, our son went into dental surgery thinking that he was ready for the outcome. He's not a stranger to the hospital. At 17, he had been under sedation many, many times. He'd had surgeries and procedures, coped with chronic, complex pain, and therapeutic procedures as elements of managing his rare disease. We did not expect him to wake up to a new, unremitting pain. We were given his opioid prescription for short-term post-surgical pain, a follow-up number to call after a few days, and we drove the hour and a half home to our small town. He was screaming in pain, but we assumed it would get better. I didn't know how to comfort him, and we didn't know where to turn to for answers when we realized that getting this episode of pain under control would require a different set of tools than what we were used to using for the past many, many years. In fact, it would require the use of opioids in a way that we weren't used to. We were far from the children's hospital. We were far from resources and had no proper decision tree or resources to know what was the right thing to do. We had our family doctor, we had our local ER, and a couple of phone numbers. We had nobody with the knowledge of how to use opioids properly for a teenager or knew Zach's whole medical story. And that's where it truly fell apart for us. We had questions about opioid use. Would Zach get addicted? Was this dangerous? How do we explain his use of opioids to the family, to him, to the other healthcare providers in the ER? How do we put the use of opioids for his current new pain within the context of his many other symptoms that we manage for his rare disease? How do we manage side effects? Because clearly, it was the only thing that was keeping his pain under control. Is anyone at all taking responsibility for this coordination? The answer to these questions was a void that left him in pain for too long. A void that led to an ER doctor telling our 17-year-old in devastating pain that he was addicted to opioids 2 weeks post-surgery. A void that led to more than one ER visit where the healthcare providers would rather see him scream in pain for 2 hours than administer the opioids for pain relief. Clearly, the resources needed, not just for families, but also for clinicians, either don't exist or aren't being shared. Thank you.
Thank you, Isabel. So like Isabel, these resources were not made available to us at the time my son Matthew was prescribed opioids for his severe pain. The main difference in our experience is that we were very lucky to have a medical team readily available to help. As well, we had an experience, as I know Isabel does, in navigating the healthcare system. Many other people do not. Even with this, having resources we could have accessed on our own would have made this journey much smoother. In reviewing what is available to families now, I found much of the same as Isabel did. The information is repetitive and focused heavily on warning and safety, how to store, how long to take. Many parents and children or youth struggle with the stigma and fear of opioids. While of course safety is paramount, without other resources that explain or acknowledge the benefit in properly prescribed pain medication, many children continue to live with unnecessary pain. I'd also like to point out, while these resources would be considered current, none of them mention naloxone kits, which of course are now available free at any pharmacy. This is a good reminder that information is constantly changing, and it's so important to be sure what's being shared is up to date. I'll give you a very brief background on Matthew's story. Matthew was healthy and typical until the age of 6 when he began to have seizures. This resulted in an 18-month hospitalization in both Ottawa and Toronto and resulted in Matthew losing his speech, mobility, and becoming G-tube fed. He had no neurological diagnosis, but was diagnosed with an autoimmune condition called Perry-Romberg. We settled into a new life. Primarily, we managed his seizures and adjusted to having a severe disability in our family. In 2017, approximately 4.5 years after he became ill, there was an incidental finding that Matthew had a hip subluxation. We figured out this was due to his seizures, as the seizures affect his left side. We managed this by adapting his positioning, and Matthew seemed to be coping okay. By the end of 2018, he went into a severe pain crisis. His seizures went up exponentially, and there was no comfortable position we could get him in. We wound up at Roger Nielsen House, which is a palliative care hospice here in Ottawa. Matthew refused initially to try the pain medication his physician was suggesting. Over a couple of days, his condition worsened to the point where he wasn't even tolerating any of his feeds. We had many discussions with his doctor. While Matthew is nonverbal, it's important to understand that cognitively he is age appropriate. He is very involved in all his medical decisions. So we were hesitant to go against what he was saying. One of his trusted physicians finally realized in a discussion with him that his hesitation came out of fear. He'd seen the commercials about fentanyl. He'd heard about what's been happening to kids on fentanyl in the news, and he was terrified that trying a fentanyl patch would mean uncertain death. Once this was explained to him and we started trying the opioids, we saw a difference in Matthew's pain. It wasn't an easy road. We had to try many different medications in a short period of time. Some of the side effects were terrible. I was grateful to have somebody there to be able to explain that just because there was a terrible side effect with one medication didn't preclude him from trying others. We finally found the right combination, a multimodal approach of using medications, procedures, and physiotherapy. I'm going to note here that while physiotherapy is often mentioned in a multimodal approach, many people do not have access to regular physiotherapy because it is very cost prohibitive. Back to our story. There was a total change in Matthew. His seizures went down. His appearance changed, and he was actually able to start eating by mouth after many years. The photos that I have up here are just an illustration of how things looked. The picture on your far left is Matthew and the way that Matthew sort of appeared over a couple of years. We assumed, as well as his medical teams, that the look on his face with the droopy mouth and eyes was a result of medication or perhaps disease progression. What we didn't realize as in fact it was directly related to pain. The photo in the middle is a photo of Matthew once we first started the opioids and he began having some relief. This was a huge change for us, and we thought that this was the best place for Matthew to be. The third picture is after he had a procedure done in combination with the medication. As you can see, he began to smile. We hadn't seen Matthew smile for more than 2 years. Everything happened so gradually with the buildup of his pain until the very acute incidents. We didn't even realize that Matthew was struggling with pain. In fact, Matthew had adjusted to a baseline of pain, so even he did not realize that he had underlying pain. When he would rate between 0 and 10, what he would rate as a 0 was likely a 5 or higher to any of us or to someone who doesn't have underlying pain. We're now in a position where Matthew's pain is still not always controlled. He does not need regular opioids anymore, but we definitely have them on hand to give whenever he does need them. I'm hoping that in moving forward, other kids will not have to go through what Matthew went through, including dealing with the pain and not being diagnosed, but also as well as some of the side effects or the fear around taking the medication. Thank you.
So this is Isabel again, and where we actually make you folks do some work that are attending the webinar, because this is really about creating and sharing resources and best practices. And what we'd like to hear from you is to join in this poll and tell us about what you know about any resources or best practices that can support the use of opioids at home in the community. Steph and I shared our stories, and really it's important to know that these are just two stories that represent only two perspectives, but there's people that have other barriers as well out there. So the kinds of things that we're looking for are resources and best practices that coordinate care between the original prescribing doctor and the general health team that might be in their home community or their home, so pharmacists, local doctors, family doctors, that kind of thing. Resources that might have to do with talking to the child themselves, the youth, or the caregivers about the stigma they may feel around opioid use or they may receive from other healthcare professionals. That's happened to our family. It was a huge barrier for us. Any resources that talk to what happens if for a backup plan if the pain doesn't go away. Resources having to do with safe use of storage outside of a healthcare center, including schools, because that's not often thought about, because disabled folks and kids don't just exist in their homes. So you can type in the poll that you see in front of you. You can type your answers and they'll pop up in an anonymous manner. What I'm seeing come up is, oh, it's going to come up fast. That's great. So if you could tap in the poll rather than the chat, it'll be easier for me to keep up, because then I won't be looking in two places, and for Steph to keep up as well. So I'm seeing pharmacists are key in this, and having a complex care coordinator. I love the idea of a complex care coordinator, but that's an access that most kids don't have. That's a wonderful thing, but it's super under-resourced. I know for us in our small town, our pharmacist is a key member of our healthcare team. So yes, pharmacist-facing resources and resources for pharmacists to give to families are really important. I know that is for us. I'm reading another one. We are currently working on a family-facing opioid handout for families in the ER. I'm curious whether you're doing that with patients and families, co-creating with you. I don't know who typed that in and where you're located, but if you wanted to type in more, there's definitely resources on how to do that with families and patients in order to make sure that they're actually what families and patients need and put in ways that are appropriate. What else do we have there? Feel free to chime in as well, Steph, so that I don't have to be the only one catching up on texts there. Oh yes, there's something there with the transitional pain services at sick kids, bridging pain care between hospital and home. I think that's a really important service. What else do I have in there? Oh, there's a handout.
The first, oh, sorry, Isabel, the first key there, the first point there about the pharmacist, I think that is key too, and there needs to be more coordinated care between the healthcare providers as well as the pharmacists, because it's the pharmacists that the families are seeing face-to-face regularly once their child is using the medication.
Yeah. Yeah, and somebody else wrote it about pharmacists working in acute pediatrics linking with community pharmacists. That's really important as well. For those folks that are creating resources, you can look to patientsincluded.org about some guidelines on how to work with patients and families in an ethical way in order to create resources that work for patients and families.
Yeah, and there's such a big range of people's experiences, and and coming into managing acute pain with children, that it's important to make sure that you have approaches from different experiences, whether it's a chronic care child or, like Isabel said, someone who's come in for dental surgery.
Yeah, and also looking at it through an equity and diversity lens, because people are coming from different backgrounds and experiences themselves, and what may be an approachable resource for one person may not be for another. So it's important to engage with diverse people that may experience different barriers in the healthcare system. It's not an equitable system.
I see too that Jennifer posted in the chat box around having a suggestion to convene families, children, and youth. That's an important part too, is for the children and youth who are old enough or able to understand, they should be directly involved in the explanation of these medications, side effects. It would be great to have resources that were directed at them, so it's easier for them to understand. It also empowers them in taking care of themselves and advocating for themselves.
Absolutely, because their concerns could come from a very different lens than a parent or caregiver's concern. You know, they're their own independent people. You know, from our point of view, we had about a year and a half ago a young woman in our son's cohort who passed away of a fentanyl overdose. And, you know, I know that that was in Zach's mind when he was being prescribed opioids, and also in his friends' minds, or you know, our local healthcare providers' minds. Like, this was a kid his age, and these are things that are top of mind in a community, especially smaller communities. What else do we see coming up? And feel free, if I'm missing something, Brady or Katie, to pop in there too.
The sharing of ideas within healthcare providers, there's such a wide range of medications, and what I didn't understand in coming into this was that they all work differently. So, you know, when one didn't work, we were very frustrated and thinking, oh my gosh, what are we going to do? The medication doesn't work, and not realizing that, you know, morphine works differently than methadone, works differently than Dilaudid, and the same with side effects. You might have side effects with one but not with another, but that's information that I didn't have. And when we had a rotating team coming through palliative care, so we got many different doctors' perspectives, which in the end, especially for side effects, one of the physicians recommended a medication to reverse the effects on the gut from the opioids, and that was a lifesaver for us. And anybody that we've spoken to, people haven't even heard of it. So if we had, if there was a way for people to share more of this information, I know there's lots of ways out there, but in condensing stuff and targeting it towards kids, because the adult information out there doesn't always transfer to caring for a child or youth.
Into trouble with kind of gatekeeping information. Like, there was no, it became very clear that that was the only way that we were going to be controlling Zach's pain for the time being. And he was, you know, he was having kind of the usual gut side effects from the opioid use that were exacerbated by his rare disease. And there was very little talk with us about how we could deal with the side effects. There was a lot of talk about, side effects, but none about, okay, given that we need to get his pain under control, how do we then deal with the side effects? So there's no kind of global talk about how do we deal with that. So I think that's something to be talked about as well.
Mm-hmm. Absolutely.
And I'd hate to interrupt, but I would just like to give a 1-minute warning before we move on to Samina's slides.
Thank you very much, Brady. I love all the comments being put into the poll and into the chat. I really appreciate that people are really thinking about how we can do this better and how we can bring families.
That's great, and I know that another piece of it is a peer connection, both for caregivers but also for the children and youth. CHIO has a program where they do have support groups, I believe, for kids who are, I mean, I guess it would be more chronic, but even in acute pain, if there was a way to allow the families to connect with other families. That's often how we solve a lot of the issues that come up, is in talking with other families in the same situation. So finding a way to connect people so that it allows them to do that.
Yeah, I think in a lot of this with the healthcare providers and the patients and families to not be afraid to reach out and make the connections, and not be afraid for patients and families to make those connections and to help them do that. I think, you know, that's how we best go forward, is to make those intersections and see what kind of magic comes out of that.
And then it normalizes as well what these children and youth are going through when they know other people are going through the same thing and have the same questions and concerns.
Yeah, and that helps reduce the stigma as well, like within the patients and families, but also within the healthcare system. There's a lot of stigma as well there, not just with the medications, but with pain itself and as an invisible disability. Yeah.
I see that a lot, especially in nonverbal kids, where it's difficult to recognize their pain, where, you know, parents are often the ones that know the most, but it can be very hard to explain to a professional why you think that's happening when there's nothing concrete to show.
Yeah, yeah. Well, I think we should wrap this up and give some time back to the webinar, and I appreciate everybody's kind attention to this, and thanks for giving us an opportunity to talk about this. It's really important to our family, and I'll let you wrap it up, Steph.
Yes, thank you very much, everyone, for listening to our stories. It's not always easy to tell, but when we're looking at the greater good, if we can help not only our own families moving forward, but other people that are out there struggling. That's the whole point of us being involved in exercises like this. Thank you, everyone.
Thank you, and I will now hand it over to Samina.
Thank you so much, Brady, Isabel, Stephanie. A very powerful sharing of your experiences and your family's experiences. In order to address some of what Stephanie and Isabel have talked about, where as clinicians, as healthcare practitioners, we don't all have the same information, we don't have the same access to information, and then in some cases there are gaps or missing information. This group that convened in February tried to bring together the resources that we knew of from our own organizations and those of others to create the beginnings of a list of resources that we could use to help healthcare providers get the information that they needed to better serve families such as Isabel and Stephanie's. And this is just the beginning of a list. And what I've done is try to provide some exemplars of what is out there that highlights different ways that providers can receive education. And as I'm working through the next 5 or 6 exemplars, I would love for you all to think about what you use and what you know of. That's excellent, because at the end of this bit, I will definitely ask you to tell us about more tools so that we can expand this list and hopefully entice you to join our group and continue to work with us to make this as comprehensive as possible. So one of the tools we have are clinical guidelines, and we're used to these as clinicians. One that I wanted to highlight today was created by the Alberta Dental Association and College, or the ADA&C, and what they had done was recognizing that dental professionals do prescribe opioids fairly frequently for post-dental procedure pain, and in fact recent work points to a great number of opioid prescriptions for children coming from dental practices. They proactively, about 5 years ago, created a guide for pain management and opioids to help assist Alberta dentists with making these decisions for their patients. And while it is 5 years old and all these documents are living documents that need to be, or need to be revised regularly because our information changes so rapidly in recent years, the principles that they embody still remain true. So for instance, they talk about really decreasing the number of pills that are prescribed to match the expected painful period. And we are starting to see this expanding into other domains as well, emergency medicine, post-operative pain management, that in general, 2 to 3 days is the maximum period of pain, or the period where there is maximal pain. So for the first prescriptions, probably limiting to 5 to 10 pills makes sense for most minor procedures. Now, of course, that can only be done if you give the family a clear and comprehensive way to access further pain management if it is not enough. But that's a nice beginning way to start limiting the total number of unused pills that are in the community. They talk about acetaminophen as being their go-to medication, and that might be something that needs to be revisited in recent days with the increasing evidence on ibuprofen. But the general principle they embody is non-opioid pain medications first before moving to something that is opioid-based. The Hospital for Sick Children or Sick Kids in Toronto has a wonderful example of educational resources. So say you are a healthcare professional who wants to understand children's pain better. They have an online pediatric pain curriculum that is free. It's available and to all healthcare practitioners, and it includes modules ranging from basic neurobiology, so basic science, to proper measurement that is developmentally appropriate, and on to prescription and choosing the correct agent. So a wonderful resource to check out. Another example comes from Health Quality Ontario, where they created a health standard. And this health quality standard was created with the intentions of trying to guide prescribing. Now, the caveat for this is it's for 15 years of age and older, but there are many principles and tools that are part of this toolkit that we could use for younger children. And of course, we all know that that 15 to 18-year-old range of patients that we might see are at developmental risk for opioid misuse as are adults, so I'm glad they've included them in this document. The quality standards addresses assessment, the very important concept of multimodal therapy, so not forgetting that pain medicine doesn't need to be used in isolation and should not be used in isolation, that we should be using multimodal therapy. It talks about dosing, duration of therapy, and what to do when someone who has chronic pain, which we know is about 1 out of 5 children in Canada, also has an acute exacerbation or a new injury where we now have to try to figure out how to prescribe on top of what they're already taking. So they also in this toolkit had many, many pieces, and I love that they have this wonderful infographic. They have guides to help healthcare facilities who want to put this standard into practice on how to get started, and they have patient-facing references as well. They had a patient reference guide, so a patient themselves, the family themselves can understand what is being expected through this quality standard. Another example of ways we can share information is when something important happens, or as a community we recognize that there are safety issues within our practice for treating children's pain. And ISMP, Institute for Safe Medication Practices in Canada, creates these safety bulletins. And this is an example of one that was created for around a critical event exemplar. And the exemplar they used in this was the use of hydromorphone, where a patient was receiving it as a continuous infusion, and when they needed breakthrough medication, they received a 10-fold dose, and it led to adverse events for the family. And this bulletin talks about how this happened through a lens of trying to identify how this happened, as opposed to laying blame on the hand that pushed the button. It looked at it from a patient safety lens, and ultimately led to the creation of Children's Healthcare Canada's toolkit, of pediatric opioid safety resource, which was created a number of years ago, about a decade ago, so it's looking for review and update, that had a wonderful message of simplifying it down to what medications should we be using in what settings. And the short list was morphine, hydromorphone, and fentanyl would be the 3 opioids that we use the most in pediatrics. And one part of the messaging in this that I appreciated was it said, but if you're not an institution that uses these medications regularly and has a large proportion of pediatric population, choose one and stick with it. And the one they had highlighted as being the safer of the options was morphine. So that messaging allows an institution or an individual to become an expert in a single medication, making it less likely to mix up dosing, or allows the individuals at that institution to develop a level of comfort with it. And they all work quite well. They have, of course, a lot of caveats around why you may or may not just choose morphine, but I really like that idea of developing expertise in one area and sticking with it. So that's another resource. The last resource I'll mention is from the Canadian Agency for Drugs and Technologies at CADIF, and they provide a number of reviews to help us understand the actual evidence behind a medication. And I loved this one in particular that came out last year. Yeah, even though we all know that Health Canada has recommended against the use of codeine approximately 5 years ago, it is still in the community and it hasn't been completely eliminated from use. So this review, systematic review, and review of systematic reviews and trials reminded us that when we compared codeine to acetaminophen and ibuprofen, there was no difference in clinical effectiveness. So it added nothing compared to just using nice, simple acetaminophen or ibuprofen. And then it also pointed out to us that when we looked at adverse events and whether they were serious adverse events or what we often refer to as side effects, so all the more minor adverse events that happen with codeine, that codeine across the board had higher adverse events than acetaminophen and ibuprofen. So it begs the question, why would we ever use this in pediatrics or for children? So CADIF has these wonderful reviews that we can find as well. So I can see there's been lots of activity in our chat box, which is really exciting. I'm going to read through that and talk to you about it. And while we're doing that, maybe we'll open this poll, and I suspect some of it is going to overlap with what I'm already seeing in the chat box. The question I'd like to pose to all of you is, what tools and strategies can health professionals and healthcare providers use to promote effective and safe prescribing of opioids for pain in children? And as you're putting in your answers, perhaps I'll try to scan some of what I'm seeing in the chat box. And someone, Amy Mott, has said 5 to 10 pills after a dental procedure. My 16-year-old was offered a prescription that would have given him closer to 24 pills for a non-complicated wisdom tooth extraction. And absolutely, thank you for sharing that. This is part of why recent studies have shown that through prescribing, through dental practice, it does put quite a large number of excess pills that are unused or unused pills into the community. And if we start moving towards the smaller pill prescribing, and I don't mean to pick on dental practitioners. As an emergency physician, we have this issue as well, as do our surgical colleagues after operative procedures that are not major. So all of us can change our practice to decrease the number of pills we put out. But I would be remiss if I didn't say that when you do this, you have to make sure the family has a safety net plan for if it is not enough. Otherwise, we are doing a disservice to that small group of patients that will not do well with just the 5 to 10. Someone has written, I'm curious if there are any tools that help clinicians speak to patients and families about bias in a safe and trauma-informed way. Great question. To my knowledge, no, but if anyone knows of some, we would love to hear about it and would love to have you join this community that we're creating here to try to address these issues. I'm just going to go back to our chat box here. Sorry, there's so much happening. We have a comment. Note that the Alberta Dental Guide shown here is recommending codeine as a choice after NSAIDs. They do give warnings about it, but it's very weak. Absolutely, and this is why no tool that we've that is, you know, a few years old is perfect, because much of this information may have come out before or after, and this is why we're having this community meeting to try to update and identify the tools that are more comprehensive and up to date. Absolutely, thank you for that comment. Someone has said, prescribe fewer pills in the community and see them if pain continues. Absolutely. Cannot stress the importance of that safety net of what to do if it's not enough. Otherwise, I think we're taking many steps back. We have a comment, prescribe acetaminophen and or NSAIDs at the same time as the opioids, then educate caregivers on how to use them together at first, and then after they are able to stop the opioids, they have non-opioid agents readily available. Absolutely. So basic principles in sort of pain management ladders would always say to start non-opioid first. I agree with you 100%, and then integrate opioids as co-therapy, never monotherapy, and then that facilitates minusing the opioids as time goes on and leaving the non-opioid medications there. And there's a comment, inform pharmacies such that codeine-containing medications prescribed to children will not be filled or will be reviewed with a prescribing provider. That's a very compelling idea. If we can work with our national pharmacy organizations to red flag codeine prescriptions, because there are exceptions. So if you have, for instance, a teen adolescent patient with sickle cell anemia whose crises have been well handled with pain crises have been well treated with codeine for 15 years, we're not going to stop that. It's working, right? But would I start a new patient on it? No. Follow up to previous, I think it's hard and possibly unfair for clinicians to talk about bias without being given tools to do so. Absolutely. There's a lot of pressure on our health professionals to know so much. We have to make this easier for them, 100%. Yeah. And yeah, please, I hear Brady on the line, I think.
Yes, I'm just going to give a brief 1-minute warning. So if we could just wrap up this amazing discussion that's happening both in the chat box and on the poll.
Wonderful. Thank you so much, Brady. This is incredible. I'm loving the engagement, and I'll take a moment again to just remind everyone who's giving these incredible comments, please stay engaged. And I think towards the end, our hosts, Dr. Bernie and Brady, will help remind us how to stay engaged. I don't think I'm going to be able to get through all these incredible comments, but there is so much excellent information and conversation happening in the chat box as well. So we'll keep this conversation alive after as well, and invite you to join us in this mission, because there's a lot of incredible energy that I can feel through this chat box. With that, I'll hand it back to Brady. Thank you so much for your time.
Thank you, and thanks to the audience. So I will actually turn to Katie to help us wrap up. Katie, on to you.
Thanks, Brady, and thank you very much, Dr. Ellie, for sharing all of that. So I think one of the things that came from our scoping meeting in February was this really key point of how can we collaborate and coordinate and really build on this synergy and this energy that Dr. Ali was mentioning. And really what we make, you know, coming out of that, and I think would invite all of you to join us in this commitment, is to partner with children, youth caregivers, and healthcare providers to inform creation and sharing of resources and to spread best practices, to collaborate with yourselves in pan-Canadian health organizations and stakeholders in this area, to convene some policy and system level discussions to promote safe and effective prescribing, dispensing, and disposal practices. And with that intention, to create an advisory group to inform the best way forward so that we can ensure that our goals, our communal goals here are really met. So we invite you to join and to identify yourselves and really put out this call to action. So if you see yourself within this, please reach out to us. We've got our contact at Kids in Pain email there. Tell us what you're doing. Share more ideas, resources, opportunities for partnership. SKIP is very interested in engaging and continuing to build in this space and build this momentum. And as a knowledge mobilization network, we have resources and support to work with people to co-create tools, to work with organizations, or to share things that you already have that we can be further promoting and disseminating across our network and to others. So, you know, across those 100 partnerships that we mentioned, many of whom are in this relevant space of acute pain management and opioid prescribing and use for children. And I know I saw Jennifer Major from CFHI partner in this too. SKIP and CFHI both take this patient-partnered approach, you know, and so opportunities to further engage that dialogue, to bring that support, that expertise in partnership with your organization as well. And you can clearly see the critical value and importance of that through what Isabel and Stephanie shared today. We also have an executive summary document coming from our meeting in February, which is a high-level overview of our findings and recommendations and what was shared as part of that meeting, including links to resources that are ready to share now, some of which Dr. Ali mentioned, but others also, and that document is available in English and French. And with that, I will turn it over to Melissa.
Hi there. If we can just go ahead one slide, I think. Thank you. That's perfect. Thank you to CFHI and SKIP for giving us this opportunity to share our draft resource that's in development, 5 questions to ask about your medications for kids. I am patient and family advisor at ISMB Canada, and with my colleague Alice Watt, who's on the call today, we are leading this project to develop this important resource. And today's webinar has really enforced the importance of the need for this handout. As we've heard today, many children are exposed to medications from a very young age, and we have a responsibility to teach children to think critically about the medicines that they're taking. Part of that teaching is to provide vocabulary and an open channel of communication between patient and provider. The purpose of this handout is to help healthcare providers teach patients aged 8 to 12 which questions to ask so that they can learn to elicit the information that will help improve their knowledge, skills, and attitudes about medication safety. Teaching self-advocacy skills at a young age will encourage children to be critical thinkers and to ask more questions. As an elementary school teacher, I've seen children come to school with prescription creams and liquids and inhalers, tablets, and insulin. Establishing medication safety in children will create a safety mindset as they grow and develop, and we know that early intervention is key. They're being prescribed these medicines to help heal and treat, but are they being taught to ask about their potential for harm? Some children function as support and translators for their family members where there's a language barrier, and this document could support medication safety to help them navigate through what can be worrisome times. On your screen, you see an initial draft of the questions and the handout that we think are important for children to ask. And in the chat box, you will see 3 survey links, one for children, one for providers, and one for caregivers. We would be grateful if you would take the time to look at the resource and complete the applicable survey. Your feedback is going to help inform the next iteration of this handout. Thanks for listening so much. Have a great day.
So with that, I would like to thank you all very much for the excellent and engaging discussions today. We hope that you found this session informative. Once again, I would like to thank Isabel Jordan, Stephanie Paravan, Dr. Katie Burney, and Dr. Samina Ali for their excellent presentations today. And of course, thanks to you, the audience, for joining. I also forgot to mention earlier on that we also have our producers, Sheena Powell, Kelly Ripley, and Mihaela Laba behind the scenes here in Ottawa. As well, my colleague Jennifer Major has been closely listening in and following the discussion in the chat, as well as Jessica Fournier, who has been providing some of the French translation in the chat. So thanks to you all, we would not have been able to achieve what we did today without your help. And your feedback is invaluable to us for the future work CFHI and SKIP are leading and our webinar design. So we ask that you please take just a moment now to provide us some feedback on today's session. I'm going to read through the questions on this screen, and I encourage all participants to please provide your reflections. So overall, I was satisfied with my webinar experience. Overall, I was satisfied with how I was able to actively participate in the webinar. And please select all practices or resources you know more about after participating in the webinar. I would also encourage all participants to share any other feedback or chat in the chat box on the lower left-hand side. So thank you all again, and we look forward to engaging with you.
This concludes today's conference call. Thank you for participating. You may now disconnect.